Hello, my name is Seoyeon Chung, and I'm a second-year medical student at Sungkyunkwan University School of Medicine. Today, I am honored to represent the research team of Dr. Faisal Jahangiri in our paper. As a first author, I'll be presenting our systematic review on the role of intraoperative neurophysiological monitoring, or IONM, in preserving pelvic floor integrity during high-risk surgeries. So what is pelvic floor dysfunction? Pelvic floor dysfunction often results from neural injuries during various surgical procedures as listed on the slide. These injuries can cause urinary, bowel, and sexual dysfunction, significantly affecting patients' quality of life. IONM may prevent such complications by providing continuous, real-time assessment of pelvic nerve function during surgery using modalities like electromyography, bulbocavernous reflex, somatosensory evoked potentials, and motor evoked potentials. Despite its potential, pelvic-specific IONM remains underused. This is largely due to the anatomical complexity of pelvic autonomic nerves and technical difficulties with electrode placement. For this study, we hypothesized that IONM could minimize post-operative neurological deficits and maintain pelvic function or enhance them from baseline. Hence, we conducted a systematic review comparing outcomes between IONM and non-IONM cases in high-risk surgeries. Following PRISMA guidelines, we reviewed studies published between 1965 and 2024 from PubMed, ScienceDirect, and Scopus. Included studies had at least 10 human subjects and reported post-operative outcomes. We excluded case reports, conference abstracts, animal studies, and non-English publications. Such terms for IONM included external urinary sphincter monitoring, bladder EMG, bulbocavernous reflex, and pudendal nerve SSEP. For non-IONM studies, we searched terms like hysterectomy, colorectal surgery, and tethered cord release. Statistical analysis included chi-square tests and odds ratios to compare outcomes between IONM and non-IONM groups. Since gynecological, urological, and colorectal procedures were infrequently performed with IONM, our comparative analysis was limited to spinal surgeries to ensure adequate sample sizes in both the IONM and non-IONM groups. A total of 771 spinal cases were evaluated, 482 with IONM and 289 without. Post-operative outcomes for each case were categorized as improved, baseline preserved, or worsened. If you look at the bar graph, the x-axis shows these three outcome categories for both groups among spinal-related surgery, and the y-axis indicates the percentage of patients in each category. In our analysis, baseline function was preserved in about 76% in cases with IONM, compared to only 42% without it. Post-operative deterioration was lower with IONM, about 15% versus 34% in the non-IONM group. Interestingly, improvement was more common in the non-IONM group, 24% compared to 9% when IONM was used. The outcome difference between the two groups across all three categories was statistically significant, with chi-square values greater than 30 and p-values below 0.0001. Baseline function was over 4 times more likely to be preserved with IONM, while the risk of deterioration dropped by 67%. Improvement was less common in the IONM group, likely reflecting its use in higher risk surgeries. These findings reinforce our hypothesis that IONM plays a critical role in preserving neurological function and reducing surgical risk, especially in high-risk, complex spinal procedures. Now, turning to the forest plot, the high I-squared value of 98.7% reveals substantial heterogeneity across procedures, study designs, and outcome measures. This underscores a key limitation of our analysis and reflects the niche, variable nature of pelvic IONM research. Overall, IONM demonstrated a protective effect. preserving function, and reducing deterioration. Lower improvement rates in IONM cases likely reflect a case selection bias, as IONM is often used in more complex surgeries like tumor resections or congenital malformations. In contrast, non-IONM groups primarily included less complex procedures like decompressions, which naturally showed better recovery outcomes. Now, let's explore subgroup analysis. In tumor surgeries, IONM preserved function well but showed limited improvement. Non-IONM cases had higher improvement but poor preservation. In congenital malformations, IONM showed both good preservation and moderate improvement. Non-IONM cases had no improvement and high deterioration, going up to 74%. A consistent high percentage of baseline rates in different subgroups suggests that IONM serves as a critical tool for preserving baseline function. However, differing results of improvement rates depending on the procedure types show how functional improvement is more influenced by the underlying surgical complexity and confounding factors than by the use of monitoring alone. To bring everything together, our analysis shows that IONM can play an important role in preserving neural function and preventing post-operative deterioration during pelvic surgeries. We also found that functional improvement was less common in the IONM group, likely because it is mainly used in complex procedures where the goal is to maintain existing function rather than enhance it. Although our findings suggest that potential benefits of IONM in spinal procedures, their strength is limited by substantial heterogeneity among studies. This likely reflects differences in monitoring protocols, outcome measures, and follow-up duration. Also, owing to their anatomical complexity, these procedures remain a niche area without standardized monitoring guidelines. Because our analysis focused only on spinal cases, these results cannot be generalized to gynecological, urological, or colorectal fields. The small number of studies in these areas reveals a major research gap and highlights the need for standardized, multi-center studies with consistent methods. This limitation naturally leads us to consider directions for future research. Our review identified major gaps in IONM reporting standards. Although EMG was the most widely used modality, most studies failed to include essential details such as alert thresholds and technical parameters. Therefore, consistent and detailed documentation of IONM protocols and performance metrics is crucial for progress in this field. Emerging techniques such as pudendal SSCPs also require validation to define standardized stimulation parameters, recording settings, and alarm criteria. Importantly, future studies should correlate intraoperative signal changes with post-operative outcomes to confirm their clinical relevance in pelvic surgery. In addition, multimodal monitoring such as combining bladder MEPs, EMG, and BCR should be standardized to determine the most effective combinations for different surgical settings. Technological innovation should further aim to achieve less invasive signal acquisition and enable automated real-time analysis. Ultimately, large multi-center trials are needed to evaluate the impact of these techniques on post-operative dysfunction. To put everything in a nutshell, intraoperative neurophysiological monitoring represents a key advancement in pelvic floor surgery, enabling real-time neural assessment to preserve function and reduce complications. As technology evolves, its widespread adoption will be essential for improving surgical safety, optimizing patient outcomes, and driving innovation in clinical neurophysiology. Lastly, I would like to express my gratitude to my incredible team for their collaboration on this research, especially to Erica Na, my co-first author. You can scan this QR code to view our full paper, and my contact details are also provided here as well. Thank you for listening.